Assalamu alaikum. I'm really happy to be with you today. Today we are going to talk about the management of acute gout. As you all know, gout is a systemic disease that results from the deposition of the monosodium urate crystals in the tissues. Actually, if the serum uric acid increases a certain threshold, it will start to crystallize, to make crystals, and to do deposit in certain parts of the tissue. The acute gout, the gout is considered the most prevalent arthritis all over the world, with a prevalence of 1 to 4% of the general population. In the Western countries, it may reach to 3 to 6% in men and 1 to 2% in women. Some countries, this prevalence may increase to up to 10%. Usually, the hyperuricemia that results into gout, it's due to either overproduction of uric acid that accounts for 10% of the cases, or undersecretion, which accounts for 90% of cases in presence of risk factors. As a male patient with the age between 30 to 50 in males and more than 55 in females, obese patients, the overproduction, we mean by it maybe the increased dietary purine, as in increased intake of meat or seafood or beer, increased endogenous purine synthesis in case of malignancies and tumor lysis syndrome, purine salvage as in Lichtenheim syndrome, and the superactivity of phosphate pyrosulfate phosphatase sensitivity, purine breakdown, which is the glycogen storage disease. The undersecretion, which accounts for the 90%, this is the most important, and it is very important for all of us as doctors, because it happens with the urinary excretion in case of diuretics, in case of renal failure patients, the urinary reabsorption in case of alcohol intake, and the genetic defects. Usually the clinical phases of gout, it's either asymptomatic hyperuricemia. This happens when the serum uric acid reaches above the level of 7 mg per deciliter, which is 416 micromole per liter, but without any gouty arthritis or nephrolithiasis. The patient in this stage, it is asymptomatic totally. If the patient starts to have symptoms with this high uric acid, at this time we call it as acute gout, and this is our main point today, how to manage this case. Between two attacks of acute gout, the patient can go to a certain phase which is called the intercritical gout. Intercritical gout, this means that it is the phase between the two attacks where the patient is totally free. If the patient continues like this, he will go to the chronic to vicious gout. Our main goal in management is that the patient will not go through all these phases. We need to capture the patient when he's in asymptomatic hyperuricemia to see if we can keep him, to see if he needs to be treated or not, because not all cases of asymptomatic hyperuricemia need to be treated. In case he needs treatment, we can go with the treatment in order to avoid the acute attacks. If the patient got his first acute attack of gout, it's better to know how to manage this case and to follow up with the patient in order not to have the chronic vicious gout. The risk factors for developing the gout, it is the hyperuricemia itself. As we said, that there is some genetic disposition, familial enzyme defects, and other factors. In 2015, the American College of Rheumatology set the new gout classification criteria, with sensitivity of 92% and specificity of 89%, showing that the score, if it is more than 8, this means that the patient is having gout. Our main point in diagnosing gout is the deposition of monosodium urate crystals in the synovial fluid. So if you can aspirate the fluid and detect these urate crystals, this is the main point of diagnosis. Here is the classification. It has clinical part, laboratory part, and imaging part. We'll go through it quickly in order to go to the acute management. Actually, if the clinical part, if you have a pattern of joint involvement, joint or bursa involvement during past or present symptomatic episode, If this pattern, I mean that the symptoms of gout, which is the redness and pain in the joint, if it appears in the ankle, midfoot, without the first MTP joint, we give the patient 1 point. If it is with the first metatarsal joint, it is 2 points. We have some typical characteristics for the attack. Either the patient reported or we observe it during the examination. These typical characteristics, which are the erythema overlying the affected joint, that the patient cannot bear touch on pressure, difficulty in walking or in using the joint. If we have only one characteristic of this, we'll give the patient 1 point. If it's 2 characteristics, it's 2 points, and if 3, it's 3 points. The time and course of the episode. If the episode reaches a maximal pain in less than 24 hours and start to resolve within less than 14 hours with complete resolution between the 2 attacks, if we have only 1 episode from this, it's considered 1 point, and if it is recurrent, it's 2 points. The clinical evidence of tophus, if it is present, it is 4 points. Coming to the laboratory part of the criteria, serum urate. Ideally, we have to check the serum urate not during the acute attack, because sometimes during the acute attack, you will find the serum urate either normal or high or low. This is not the main point. So in the clinical criteria, they suggest that it's better to check the serum urate after at least 4 weeks from the acute attack and the patient not on the urate lowering therapy. If the serum urate came less than 4, it's minus 4 points. If it is between 6 and 8, it's 2 points. Between 8 and 10, it's 3 points. And more than 10, it's 4 points. The presence of synovial fluid analysis with the patient symptomatic. If we find that there is no monosodium urate crystals, this is minus 2. If we make the aspiration and there is no monourate crystals, it's minus 2. The imaging modalities, we can use the ultrasound or the dual energy CT where the double contour sign can be seen, or with the X-rays, it can show the erosions, X-rays of the hands and feet demonstrating erosions. This is an X-ray showing the erosions, and this is the ultrasound. I don't know if there is a pointer or not, but there is a double contour, and it shows the crystals deposition. And this is a dual energy CT. Now, in 2020, the American College of Rheumatology set some recommendations on the same clinical criteria that came that we have to make a treat-to-target goals, and gave some recommendations in the treatment that we will go through during our lecture. Starting with acute gout, this is the case. As you see, this how the patient comes. Usually, it will come it's more in males than females. Among men, it's 50%. The initial gout flares occurs in the first metatarsal joint, where we call it podagra. 85%, it will be as a monoarticular or polyarticular manifestation. Usually, the affected joint will be the first metatarsal bone, ankle, knees, wrist, or any joints of the upper or lower limb. If the patient comes, 15% of cases came with polyarticular presentation. This may happen in elderly or in postmenopausal women on diuretics, but in this case, we have to thoroughly investigate the patient in order to be sure that it's not a seronegative polyarthritis. The symptoms of acute attack, it's abrupt onset at night or early morning, severe pain, swelling, redness, hotness. Sometimes it will be with some constitutional symptoms with low-grade fever and chills, painful in touch. Usually there is periarticular inflammation around the joint itself, which we call the gouty cellulitis. There will be difficulty in walking, difficulty in doing the daily activities. Maybe there is spontaneous resolution. Some patients will go spontaneous resolution within 7 to 10 days with skin desquamation. Less common that the patient will come with tenosynovitis or bursitis. The triggering point for this gout of flares, it may be the alcohol ingestion with excess purine and fructose, colder temperatures, repetitive minor trauma, initiating urate-lowering therapy without concomitant prophylaxis, and it's a very important point that some patients, if there is asymptomatic hyperuricemia and the doctor decided to start urate-lowering therapy for the patient without concomitant prophylaxis, the thing that we'll talk about later, the patient may go up to acute flare. The presence of infection after surgery, after chemotherapy or radiotherapy, if the patient is on diuretics or if the patient is dehydrated, all this may trigger the acute flare of gout. Now we came to the point that if you have a patient referred to you, that this patient is a suspected case of gout, how you will deal with this case. As we say that our main goal of diagnosis is the monosodium urate crystals, the aspiration of the joint to see these crystals. First, we have to ask ourselves, is the doctor, can he do this aspiration or not? Sometimes the doctor doesn't have the privilege to do this aspiration. Sometimes he's not expert in it. Sometimes he is suspecting septic arthritis, which is the most important point. We have to be sure before starting our treatment. If we have monoarticular arthritis or we have redness and swelling joint, the most important differential diagnosis to be sure that it's not septic arthritis. So we say that if there is any suspicion that there is infection, if there is a suspicion that there is infection at the limb, the joint, it's warm, swollen, painful, there is constitutional symptoms, the patient came with atypical presentation, he doesn't have any signs or doesn't go with the clinical criteria with the gout, at that time, the best thing is either to do the aspiration, or if you cannot do it, is to refer the patient to another doctor or to rheumatology or something to start with the aspiration to be sure of the diagnosis. If this is not available, at that time, we will apply something called the clinical diagnostic rule. This means that if the patient is male sex, we'll give him 2 points. If he has previous out flare, it's 2 points. If it is onset less than 1 day, it's 0.5, it's half a point. Joint redness 1, first MTP joint involvement, it's 2.5. Hypertensive cardiovascular disease, it's 1.3. Serum uric acid above 5.8 is 3.5. If we apply this rule and the patient got and then counted the points that we gave to the patient, if he comes to be 4 or less, it's unlikely to be gout. We have to re-diagnose the patient, to reassess the patient once more, and to reach a diagnosis. If it is 4 to 8, it's intermediate, and mostly these patients have, and we have to conclude how to go with the patient. If it is more than 9, it's gout. Returning back to our algorithm, say that you were able to do aspiration by yourself, or you referred the patient to a rheumatologist or whatever, and we were able to do the aspiration. We have 2 points. Either the aspiration will show you the negatively birefringent needle-shaped crystals, which is a monosodium urate crystals. At that time, khalas, the diagnosis is confirmed. But what if you do the aspiration and you didn't find these needles or these crystals? According to at that time, the aspiration, we are not looking only for the crystals, we are looking for the number of cells to see if there is inflammatory cells or not, to diagnose septic arthritis. If we have another crystals like the calcium pyrophosphate crystals, or if there is any other symptoms that can appear, Gram stain positive or anything, to see through the synovial fluid examination. Now, as we reach the synovial fluid examination and we diagnose the patient, either he's having gout or not, and we reach the point that the patient is having gout. It's acute flare of gout. The first point, we have to treat the patient as early as possible. If you start the treatment before the first 24 hours, the outcome will be better than making the delayed diagnosis. The first, we have to educate the patient about the disease, about the lifestyle advices, to tell him about the triggering point, to see with the patient what are his comorbidities and what his medications. And at this point, we can counsel the patient and discuss with him the mode of starting the medications. Some patients will prefer one mode over than another. Maybe he has previous attack, maybe he used one medication that got better results, so we can discuss with him. Or if we show the patient the options, I'm sorry.
Dr. Samah, you have 2 minutes.
2 minutes?
Yeah.
I'll do it fast, don't worry. Okay. We have 3 options for treatment of acute gout. It's either non-steroidal, colchicine, and oral glucocorticoids, or intra-articular injections of glucocorticoids. According to the patient's situation, if you have a patient with a bleeding tendency, gastric problems with GIT bleeding tendency, yeah, it's better to use colchicine. Because it will not it will not cause any bleeding tendency. The dose, it's usually between 1 gram or 1.6 in the first dose, and 0.5 milligram after 1 hour. Then we can keep the patient on 0.5 milligram PID. The colchicine, it is the adverse effect with the colchicine, it's either nausea, vomiting, and cramps and abdominal pain, but be sure that your patient is not on clarithromycin, antifungal, verapamil, and diltiazem. With caution with the cholesterol-lowering medications, and avoid using colchicine in severe renal impairment. Non-steroidals, it is recommended in the acute gout we can use naproxen 250 mg BID, or we can use ibuprofen 800 BID, but be sure that the patient doesn't have any bleeding tendency, and be sure that he's not having severe renal impairment. The glucocorticoids is a good option, but we cannot use if the patient is having diabetes of high case, uncontrolled diabetes or uncontrolled hypertension. The dose of oral prednisolone, it's either 20 to 40 mg daily, tapered over 2 weeks, or we can use 1 dose of IM methylprednisolone 40 to 120. Intra-articular glucocorticoid injection, it's a very good suggestion in case that you confirm your diagnosis. Don't inject a joint that you are suspecting septic arthritis. If the patient have contraindication to all the previous things, the only thing that will go is to the interleukin-1 inhibitor with anakinra, which is a new modality, but we give it if the patient have contraindication or intolerable to the other all options. Thank you very much.